I lost my son.
I lost my husband.
पति मर गया, बर्दाश्त न कर पाई।
Every 40 seconds, someone in the world kills himself. In India, one person every 4 minutes dies because of it. It is one of the leading causes of premature death in the world, claiming the life of approximately 1 million individuals every year.
Every suicide affects at least four other members, and their risk of suicide attempt increases in return. In our country, more than 130,000 people have killed themselves in 2011. 1 in 60 people in India are affected by suicide.
Families do not talk about suicide. It is seen as shame and sin. They hide it. More than 80% of patients feel that the best way to reduce stigma is to provide treatment.
Our project is education and training for suicide prevention. Patients remain untreated and suffer detrimental consequences of suicidal behavior as well as of underlying mental illnesses. Lack of training leads to lack of appropriate services and poor awareness. Therefore, training and education, especially for people like teachers and health workers who are in direct contact with vulnerable groups, can help increase identification of individuals with related problems. They can then offer support and make a referral. Purpose of this project is to develop manpower that can aid suicide prevention in different regions globally. As the treatment of suicide behavior becomes more visible, more services are likely to be established. In this project, we propose to provide web-based resources for education applicable to individuals and organizations both. Identification of individuals who are likely to attempt suicide is extremely difficult and appears almost impossible. A detailed description of methods and measures to identify suicide and depression are covered here. These include asking key questions about suicide directly, use of screening tools, and carrying out a detailed interview. When to ask these questions?
Though many exist, one of the most common scales for identification is the Beck Suicide Ideation Scale. Prime MD is another suicide identification scale. The questions which can also detect depression are: in this, the first three questions show possibility of presence of depression.
Reading and practicing the techniques described here is likely to facilitate identification of suicidal patients amongst those who are attending primary care clinics.
It's possible for doctors to recognize the warning signs, but all need training. We need to train them.
Identification of individuals who are likely to attempt suicide is extremely difficult and appears almost impossible. Longitudinal studies have shown that the presence of certain risk factors increases the chances of prediction of suicide attempts amongst those people who have suicidal intentions. By no account, however, can these findings be generalized. Studies have shown that about 50% patients make repeated suicide attempts. For other 50%, the first attempt is the last attempt. Doctors are key personnel who are in contact with patients who attempt suicide. About 50% of patients are known to have contacted their doctor a month before making an attempt. About 10% are known to have been regularly attending the outpatient clinics. It is important to know that people who attempt suicide do actually wish to live. A recent Indian study published in 2012 in Indian Journal of Psychiatry shows that more than 80% of survivors who attempted suicide felt that their suicide attempt could have been prevented by their family members. General practice offers an opportunity of prevention because patients across all age ranges, such as adolescents, adults, and elderly, have been reported to have contacted their physician. About 30 to 70% of them had established contact within 1 month to 1 year prior to suicide. It is generally felt that adolescents do not access healthcare systems. However, studies report that about 20% of adolescents who commit suicide have visited their family physician prior to the attempt. Family physicians thus should be the primary focal point for suicide prevention. Community doctors have a special place in suicide prevention. There is a high prevalence of suicide ideation in patients attending the dispensaries and clinics. It is easier to detect and provide treatment. The doctors in clinics are strongly connected to the families and have first-hand information of their problems. They are also often the first contact of all their medical surgical problems. These doctors make arrangements for their patients' specialty treatments and even the long-term care. Thus, they get the opportunity of intervention across all risk situations.
Studies show that more than 98% of physicians feel the need for training in the field of suicide prevention. Its demand is well established. Studies have determined that GPs feel lack of support from mental health services and hence find it difficult to refer the patients on, have the patients treated early, or demand more facilities. Modern research has clearly demonstrated that training of physicians and counselors can help identify people who are suffering and successfully treat them. These attempts are largely successful in program-based community practice. One of the main challenges in identification and management of suicide behavior is that it cannot be predicted with certainty due to a number of reasons, particularly since there are no biological or physiological markers. The pathway of suicide attempt from suicide ideation is not clearly known. It is a multifactorial problem. Example, psychological, social, biological, and environmental factors have a play. Though it is difficult to prevent suicide, a number of community initiatives have successfully decreased the rate of suicide. Main examples include the Suicide Prevention Program of the US military and Defeat Depression Program of the UK. Recently published study from Slovenia showed that incorporating identification and treatment of suicide in primary care reduced the rate of suicide from 31 per 100,000 in 98 to 22 per 100,000 in 2008. A number of Indian studies have also shown that training of lay counselors, community mental health programs, and control of pesticide in rural areas have been successful in reducing the rate of suicide. Identifying suicide risk can be done by looking out for risk factors like warning signs and identifiers, or by examining for the presence of depression. A good history and clinical examination can elicit signs and symptoms of psychiatric disorders. Ways of doing so are using specific rating scales or questionnaires which have evidence-based effectiveness, promptly checking on the patient whenever suspected, incorporating risk assessment for suicide in regular clinical checkups, regular screening of patients, and by attending to the high-risk groups.
Identification of suicidality is a clinical skill. There is no method which can replace a qualitative history and examination as per standard medical procedure. Physicians' practices in our country are too busy to allow time for assessment and accurate detection of suicidal ideation. And therefore, a brief and accurate method of identification within a short period of time is necessary. Suicide and depression are clinically interlinked, and so suicide can be identified independently as well as by detecting depression in patients. Let's look at some issues with clinical presentation of suicidal intent. It is mostly the relatives and not the patients that come into the doctors to explain the clinical situations that may lead to suicide. Non-psychiatrist patients develop suicidal thoughts. Very few patients come in on their own to talk about suicide in family practice, more in Indian culture than in Western countries. There is high level of stigma attached to the issue. There is very poor awareness. Examples of suicide in treatment are either not present or not talked about. Belief in treatment is poor. Available knowledge and skills of identification is poor. Legal problems about suicide being a crime also play an important role. In our Indian culture, physicians have noted that very few patients come on their own to talk about suicidal ideas. In some situations, the physician is contacted after an attempt has been made.
This module addresses the challenges in treatment and management of suicide prevention. The discussion that follows is primarily from a clinical perspective. We will be discussing the public health issues involved in the following chapter.
Suicide attempt is one of the most difficult clinical situations to treat. Major emergencies are seen by psychiatrists. In any acute psychiatric ward, more than 70% of patients admitted have attempted suicide or are in a major suicidal crisis. There are two main challenges in developing an effective strategy. One, providing adequate treatment for those who are already in a healthcare system. The objective of this strategy is to facilitate early identification and appropriate intervention for patients who are at a high risk. The second challenge is to develop programs that can provide treatment to patients outside the system. Studies from UK and Australia suggest that only about a quarter of people who succeed in committing suicide were admitted in a healthcare system of any kind. About 18% are treated in the hospital, and about 6% are treated in other settings. Furthermore, suicide remains grossly underreported, particularly in developing countries where the actual rate of attempted suicide is at least 6 to 10 times higher. Patients attempting suicide do not access care. They have a high degree of stigma. Main roadblocks in not accessing care appears to be stigma, unawareness, and fear of discrimination, which gives rise to shame and guilt. Also, suicide is not recognized as a legitimate health issue, and a lack of services may play a contributing factor in preventing people to seek help. Now we turn our attention to the very first challenge, that is providing adequate treatment for patients in the healthcare system. Offering adequate treatment includes recognizing gaps in the treatment of suicide behavior and examining ways of filling in these gaps. For the purpose of understanding, we can divide this problem in three different subgroups. 1. Treatment before contact. 2. Treatment during contact. 3. Treatment after contact. Let us first examine factors which deter a patient from approaching a system of care. This involves enhancing contact between high-risk individuals and services. Some of these gaps are a lack of community programs, poor awareness drive, lack of effective networking, poor healthcare promotion, isolation of mental health from physical health, poor services within social agencies and healthcare system, and no consistent link between services and community. We need to identify risk factors related to suicide in order to treat such individuals. While examining treatment gaps for individuals who are in contact with services, the major task is to identify risk situations and provide management. Skills for professionals need to be improved, and we need more number of facilities to provide opportunities for care. To easily understand risk, we will divide it into 3 subgroups. First, interpersonal conflict. Second, risk situation, for example during a bereavement period. And third, individuals who are at risk, for example those with a family history of suicide. Some of the risk factors are the treatment gaps during contact. These can be a week after hospitalization, a week before hospitalization, any transition during hospitalization, a leave of absence from the hospital, a week after discharge before the first follow-up, and discharge up to 1 year. Risk is also high in patients with past attempts, recent attempts, and repeated multiple attempts. Patients with side effects, for example, extrapyramidal syndrome, akathisia, post-psychotic depression, and bipolar mixed states. Treatment gaps during contact can also include patients in partial remission, ones with psychosocial stresses during treatment, ones displaying positive symptoms, and ones with insight. After well-being, the following need to be available to ensure well-being of a patient: consistency and continuity of care, relapse prevention mechanisms, crisis support, short-stay facilities, education, rehabilitation programs, anti-stigma intervention, and a clinical database. We shall now examine some of the treatment gaps which are seen after a patient is discharged from care. From a prevention point of view, this is the most important phase. Here the benefit of treatment can sustain with good service. Poor service and shortcomings in this phase will undo the benefit of opportunity which the patient had. Some of these factors are absence of any mechanism to provide consistent and ongoing care, and also an undeveloped relapse prevention program. In general, these patients remain disconnected from the services where they were treated. When such patients face a crisis again, treatment is not easily available and they do not have any support. Facilities for short-stay treatment are also lacking. Stigma plays an important role in accessing the care for those who have been treated. An anti-stigma intervention program may go a long way in preventing a second attempt. Some useful changes in clinical practice to improve identification and intervention are community development and awareness, drive linked to services, networking with agencies, program-based intervention, early intervention across diagnosis, qualitative and quantitative risk assessment, standard of care, supervised continuity of care, specialized service for extremely high-risk patients, suicide registry, mandatory educational drive. Close networking with non-psychiatric physicians, peer review of resistant cases, follow-up treatment in primary care, clinical database, treatments, all are equally effective here, side effect checklist, inpatient facility for challenging behavior, zero tolerance for non-compliance, appropriate use of MHA, periodic review for implementation of policy. Awareness drives have been using print and electronic media, patient and relative educational program, and address specialized groups of people. These have mainly been conducted as volunteer services by mental health professionals. The fundamental gap is the absence of a link between awareness drive and service provisions. An awareness drive without facilities of service leaves vulnerable candidates with unanswered questions. People find it uncomfortable to discuss and learn more due to stigma. A comprehensive program in which awareness drive is a part of success is likely to be more beneficial. The next question arises: what can we do to deal with these gaps? We believe a lot can be achieved by improving clinical practice and program development. This can perhaps minimize the risk of suicide significantly. In clinical practice, it is evident that with experience, practices are changed to incorporate newer ideas. Service also improves. Over a period of time, a culture-specific model of care becomes possible. Cultural, economic, and social factors are important for planning preventive programs. It has been repeatedly emphasized that a number of agencies have to work together in a team spirit in a given community. These agencies must not lose the central focus of suicide prevention while working in a field of mental health. Continuous training for skill development, increasing knowledge base, constructing short specialized courses, developing training programs are some of the important steps required for maximizing outcome of efforts put in by the agencies. Agencies include health and non-health professionals, community workers, and teachers. People working in the fields are always in close contact with members of the community. This association provides an excellent opportunity for identification and also places a responsibility for suicide prevention. In a more proactive manner, an ongoing motivation of these agencies along with logistical support is imperative. Needless to say, giving up is always an easy option. In this context, working with family physicians is very important. Everyone who is involved in healthcare delivery needs to realize that working with family physicians is not an option, but it's an obligation for the development of community. An important opportunity in clinical practice is to identify people who are at high risk, as well as those who will likely become a high risk in due course of time. Such individuals who do not show frank signs and symptoms may also become a high risk for suicide by a number of impending factors, such as bad life situations, economic pressure, or academic pressure. These vulnerable candidates can be identified using the knowledge and skill which practitioners gain through education. Besides appropriate treatment, the second most important challenge is to bring more and more patients into the system of care. We refer this to as breaking the barriers. With rapid social and economic transformation, newer sets of problems arise. A number of these issues are a high risk for suicide. At the same time, newer groups of high-risk individuals also need attention. The most common risk factor is economic pressure, which is a significant factor related to suicide. Loan and unemployment are prevalent in both rural and urban communities. Farmers, students, and immigrants, as well as people with AIDS, are some of the high-risk groups that require special attention for intervention. These newer factors have a definite impact on behavior. For example, economic pressure is closely related to increased incidence of smoking and alcohol consumption. Among immigrants, a high incidence of mental disorder has been reported. This risk behavior will finally lead to mental health issue which may precipitate to a suicide attempt. While designing service, whether by government agency or by volunteer agency, we need to form an integrated approach. There are 4 components which are an integral part of such an initiative: service development, education, research, policy development. We do not need these efforts at different times. We need them all at the same time. It is not a matter of discussion that more services are required. However, while designing services, local culture, customs, traditions, and socio-economic status should be considered. There cannot be a uniform model of service a variety of services will be required to fulfill the need of a community. Ongoing education for skill development will help in manpower development and utilize service providers' capacity adequately. Research is a central part of health service development. It generates locally relevant data, which can then help to reframe or redesign the service. There is a need for a definite policy for prevention of suicide. Such policies are required to be developed for local communities and should be relevant to the given health system. For example, referring all attempted suicides to psychiatric treatment is a matter of policy. A number of hospitals do practice this. However, a large number of hospitals do not. If an attempted suicide patient is sent back without intervention, the chances of him or her repeating the attempt is high. Developing the policy needs people's participation for acceptance and implementation. There are many challenges in the treatment and management of suicide prevention. The main ones being arranging adequate treatment for those already in the healthcare system and bringing more patients into the treatment fold. Changes in practice, identifying missed opportunities, tapping into the community and reaching unreached demographics are some way of overcoming these challenges.
Welcome to Suicide Prevention, Education and Training for Health Professionals in Primary Care. Let's go over the learning objectives of this course. In this course, we will cover overview of problem, suicide as an everyday clinical problem, challenges in management and prevention of suicide, success in intervention and prevention, role of family physicians in suicide prevention, and education and training for human resource development, for example, family physicians. These resources are intended primarily for general physicians. Their objective is to outline the main disorders and other factors associated with suicide and to provide information on the identification and management of suicidal patients.
One of the worst things a physician has to face is the suicide of a patient. The common reactions experienced by physicians who have gone through such an event are disbelief, loss of confidence, anger, and shame. The suicide of a patient can trigger feelings of professional inadequacy, doubts about one's competence, and fears for one's reputation. In addition, physicians confront the enormous difficulty of dealing with the family and friends of the deceased. These resources are intended primarily for general physicians. Their objective is to outline the main disorders and other factors associated with suicide and to provide information on the identification and management of suicidal patients. Every year, about 1 million people kill themselves across the world and another 20 million make an attempt. About 4 times as many people are affected by a suicide. Suicide is preventable. Most suicidal individuals desperately want to live and often give warning signs. However, they are often unable to see alternatives to their problems. 2002 estimates showed that globally 873,000 people died from suicide. The number of incidents of self-inflicted injury was 10.2 million. Every year, almost 1 million people die from suicide, a global mortality rate of 16 per 100,000, or 1 death every 40 seconds. Suicide is one of the top 10 causes of death the world over, and is the third highest cause of death between the age group of 15 and 34. In the last 45 years, suicide rates have increased by 60% worldwide. Although traditionally suicide rates have been highest amongst the elderly, rates amongst young people have been increasing to such an extent that in a third of all countries, they are now the group at the highest risk. Mental disorders, particularly depression and those related to alcohol use, are a major risk factor for suicide in Europe and North America. In Asian countries, impulsiveness plays an important role as well. Global mortality from suicide is projected to increase from 873,000 deaths in 2002 to 1.13 million in 2030, an overall increase of 6.8%, which is consistent with the increasing number of suicides in older people due to increased lifespans. These projections do not necessarily represent reliable predictions for the future, but rather a set of visions of the future resulting from explicit assumptions, covariate projections, and starting estimates. Suicide is a highly stigmatized condition, and this is one of the reasons why people do not access care. The immense psychological and social impact of suicide on family and society can be described by these figures. Each victim, on an average, affects at least 6 other people. When suicide occurs in a school or workplace, hundreds of people are affected. Studies suggest that only about a quarter of people who kill themselves are in any healthcare system. About 18% are treated in the hospital and about 6% are treated in other settings. This data is based upon population studies carried out in countries like UK and Australia. At this juncture, we need to realize that suicide remains grossly underreported, particularly in developing countries. The actual rate of attempted suicide is at least 6 to 10 times more than that reported. Main roadblocks in not accessing care appear to be stigma, unawareness, prejudice, determination, shame, guilt, lack of services, and the fact that suicide is not recognized as a health issue. Main roadblocks in not accessing care appear to be stigma, unawareness, prejudice, discrimination, shame, guilt, lack of services, and suicide not being recognized as a health issue. The burden of suicide can be estimated in terms of disability adjusted life years. This measure varies between 2.3% in high income countries and 1.7% in low income countries. This is equal to the burden due to wars and homicide, roughly twice the burden of diabetes, and equal to the burden of birth asphyxia and trauma. The Global Burden of Disease, GBD, or Global Burden of Disease Study, is a comprehensive regional and global assessment of mortality and disability from major diseases, injuries, and risk factors. Suicide worldwide represented 1.8% of the total global burden of disease in 1998 and is predicted to rise to 2.4% in countries with market and former social economies by 2020. Worldwide, the prevention of suicide has not been adequately addressed due to basically a lack of awareness of suicide as a major problem and the taboo in many societies that is associated with it. In fact, only a few countries have included prevention of suicide among their priorities. Reliability of suicide certification and reporting is an issue in great need of improvement. It is clear that suicide prevention requires intervention also from outside the health sector and calls for an innovative, comprehensive, multi-sectoral approach, including both health and non-health sectors. For example, education, labor, police, justice, religion, law, politics, and the media. Let's look at the subset of low and middle income countries. In South Asia's low middle income countries, Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka, based upon the Mathers-Lonker analysis, aggregate population experienced an estimate 226,000 deaths due to suicide in 2020, which is about 1.65% of all deaths. Some increase is projected for the year 2030, with total number of deaths nearing 300,000 and making up 1.80% of all deaths. Suicide in India is a socio-cultural problem. In a vast majority of cases, only social factors are responsible for suicide. National data shows that the main causes can be grouped into family-related and illness-related issues. Illness-related issues include chronic physical disorders, mental disorders, and substance abuse like alcohol and drug addiction. Rural population is generally migrating to cities, and changing demographics are making the task of suicide prevention further difficult, as the migrating population does not tend to access established healthcare systems. A major problem in suicide are rural areas. Identification and treatment of these patients in rural areas remains challenging because hardly any facilities exist for this purpose. In conclusion, suicide prevention is important across all health and non-health settings. The main requirements remain dealing with stigma and developing awareness.
Suicide is a major preventable cause of premature death, influenced by psychosocial, cultural, and environmental risk factors. Suicide behavior cannot be predicted with certainty.
One of the main barriers for suicide prevention is stigma. Families do not talk about suicide. It is seen as shame and sin. They hide it. The stigma thus perpetuates suicidal thought and leads to further attempts of suicide. We must realize that stigma is a clinical risk and needs to be dealt with clinical measures. In one of our studies conducted in Mumbai, 300 patients asked about measures for reducing stigma. It was heartening to see that a large number of patients believed that stigma can be reduced. More than 80% of patients feel that the best way to reduce stigma is to provide treatment.
This chapter takes an in-depth look at suicide as an everyday clinical problem. A large body of research is available to support this viewpoint. However, this viewpoint has generally remained neglected. If we look at the problem of suicide behavior from a general health perspective, it becomes clear that it is an issue of day-to-day health since it is seen across all health conditions. There is sufficient evidence that suicide behavior is related to general health of an individual. Some supporting factors are physical illnesses. They are a cause for suicide in a significant proportion of patients. A sizable number of patients suffering from physical disorders attempt suicide. People with suicidal ideas and those experiencing suicidal crisis first go to a general health setting for treatment. A number of medications used to treat physical disorders can lead to depression and suicide. And finally, an adequate management of physical illness improves the outcome of depression and can minimize suicidal potential and suicide ideation. In fact, medical illnesses themselves are one of the major causes of suicide. A number of people suffering from general medical and surgical conditions attempt suicide. This is why suicide behavior should be an important part of day-to-day clinical work.
Clinical priorities in primary care are set for a change. Though a very small proportion of people visiting a primary care facility may actually go on to make an attempt, about 30 to 35% of all the patients attending such clinics have suicidal ideas. Identification and treatment of those having suicidal ideas, crisis, or those who have made an attempt is now an important part of the clinical responsibility of family physicians.
Priorities of family physicians are changing as a result of the changing profiles and characteristics of patients attending primary care clinics. More psychosomatic and non-communicable diseases are now seen in community care clinics. Similarly, these clinics are also an entry point for suicide prevention, and more often than not, these physicians are the first contact for patients who have suicidal ideas. At any given point, about 10 to 15% of people in the general population have suicidal ideation.
A large number of physicians feel that they have an urgent need for acquiring knowledge and skills to identify mental health problems, particularly depression and suicide. There is strong evidence that training and education of primary care physicians is one of the most effective methods of suicide prevention.
Suicide is multifactorial and complex, wherein general health is an important contributing factor. Contemporary understanding is that suicide behavior is multifactorial and arises from a complex interaction of social, psychological, cultural, and environmental factors.
A number of factors contribute to emergence of suicidal ideas and behavior. Example, psychological distress, adverse social conditions, presence of mental disorders, etc. An individual's faith, conviction, and beliefs also significantly contribute to suicidal ideas. Medical illnesses and general health are two main factors which contribute to the pathogenesis of suicide, and therefore, specific and particular attention needs to be paid to these issues. Mainly because a number of conditions can either be successfully treated or at least have their impact minimized, thus, creating a conducive environment for treatment of a patient who is undergoing a suicidal crisis is paramount.
Physical illness is a cause for suicide in a significant proportion of patients. 1 in 10 suicides is among people with a physical illness. It is natural to wonder why suicide behavior is a clinical and health problem. A few major arguments for this are the fact that physical illnesses are a cause for suicide in a significant proportion of patients. People having suicidal ideas and experiencing suicidal crisis are seen across all health settings. A number of medications used to treat physical disorders do lead to depression and suicide. And finally, an adequate management of physical illness improves the outcome of depression and can minimize suicide potential and ideation. Furthermore, a qualitative management of psychiatric disorder can reduce physical morbidity amongst mentally ill persons. It is logical to ask how physical conditions can lead to suicide behavior. This is not known with certainty. However, clinical depression is the final common emotion for a number of factors leading to a suicide attempt, which some physical conditions can lead to. A number of factors determine the origin and course of physical disorders. Personal factors, psychosocial and cultural factors, along with variety of mental disorders can cause or contribute to a physical disorder. These physical disorders lead to depression and hopelessness by a psychobiological pathway, which then leads to depression and suicide. A recent study in patients suffering from chronic health conditions showed that about 15% of subjects had active suicidal ideas, of which about 3% had to be hospitalized for immediate treatment. Of those with suicidal ideation, about 20% had a plan, 24% had an active ideation without a plan, and about 56% had passive ideation. One study showed that a number of subjects with suicidal ideas do get hospitalized because of medical illness. In this study of more than 27,000 patients of attempted suicide who were analyzed for variables of hospitalization, it was found that 63% of patients were hospitalized due to a medical disorder, as against 44% in comparative groups. Risk of subsequent suicide was 2 times more amongst these patients than amongst the comparative group.
Suicide rates and mental disorders are associated with poor medical conditions. The National Crime Records Bureau in India collects data about suicide from all over the country as reported by the police departments. According to their data, about 134,000 people committed suicide in 2011 across India. The most prominent causes were family issues, medical illnesses, and mental illnesses. Looking at the number of cases, the causes of suicide can be regrouped into 3 major ones: family problems, medical illnesses, and mental disorders.
Studies screening patients attending emergency departments have found that a significant percentage of non suicidal patients also have suicidal ideas. Hence, it is clear that emergency room psychiatry occupies a prime position for the implementation of preventative programs. The fact that the emergency room is currently seen as a major resource connecting several other departments in general hospitals is a bonus. It is ideally placed to strategically coordinate policies and programs for suicide identification. A study published in 2012 expands on this. Of patients attending emergency rooms in Korea, in a follow up of 2 to 5 years, the suicide mortality rate was 82 times higher amongst those who were hospitalized after an attempt. In addition, the suicide mortality rate was 11 times higher than normal, even amongst patients who were non suicidal and had been discharged from the emergency room. In a study to evaluate competencies of identification of physicians and nurses in the ER, a screening tool was given to them. The study showed that 37% of nurses were able to identify suicidal patients as against 7% of physicians. This study highlights the need for training and education for emergency room physicians. Consultation liaison aid in psychiatry. As stated previously, suicide has a significant interface with physical disorders. High risk of suicide has been reported in a number of medical disorders. Severe mental illness also has a prevalence of physical illnesses. Consultation liaison aid in psychiatry is a branch which primarily deals with psychiatric disorders present in patients admitted in non-psychiatric medical facilities. This field offers opportunities for intervention as well as prevention. It facilitates early diagnosis and treatment of psychiatric disorders present in medical illnesses. Commonest conditions seen by CL psychiatrists are depression, suicidal ideation, anxiety, issues related to trauma, and psychosocial stressors.
As stated earlier, individuals having suicidal ideas are present across all health settings. A number of studies have been carried out to examine individuals with suicidal behavior amongst people in the following setups: those visiting the emergency rooms of a general hospital, those that were hospitalized, those seen in community, and those who attend healthcare facilities for general health conditions like obesity, tension, and stress problem. In the case of general hospital admissions, the rate of suicide is high when terminal and incurable conditions are involved. For example, in HIV or renal transplants. The Harris and Baraclough studies of 1994 and 1997 have shown that standard mortality rate for suicide is significantly higher in patients with certain medical disorders. The findings of such studies are very important for organizing care for patients at a very high risk for suicide. The medical team treating these patients needs a consistent, collaborative care with mental health professionals in order to prevent suicide and other psychiatric diseases. Another study recently published highlights the importance of physical illness amongst individuals with suicide behavior. 1,877 suicide victims studied were divided into two groups: those hospitalized with depression and those who were not hospitalized. Significantly more number of suicide victims who were hospitalized due to depression also had physical disorder. This was more common in females. Common physical illnesses seen in such patients are obesity, metabolic syndrome, diabetes, cardiovascular diseases, respiratory diseases, HIV, AIDS, and communicable diseases. Some common risk factors for females are coronary heart disease, stroke, chronic obstructive pulmonary disease, and osteoporosis. Contrarily, deterioration of physical condition is related to more resistant form of psychiatric condition, for example, depression coexisting with diabetes mellitus. A poor control of diabetes increases the severity of depression, which in turn worsens glucose metabolism. Suicidal ideation is more frequent and severe in treatment-resistant psychiatric conditions. Therefore, persistent depression with medical illnesses are more severe. Duration of antidepressant therapy required is relatively shorter and relapses are not very frequent except in patients who are vulnerable and have depression in a pre-existing medical condition. In some CNS conditions, depression and suicide can be due to direct neuropsychiatric effect of the medical disorder. For example, post-stroke depression, which is relatively more severe. Though it is not well understood how physical disorders lead to suicidal ideation, however, final common emotions found are depression and hopelessness. It is likely that most medical conditions lead to the emotional response of depression, which in conjunction with several psychosocial factors may be responsible for suicidal ideation.
An important support to the concept that suicide is a health issue is also available from the data showing that the improvement in severity of the physical disorder can reduce severity of psychiatric conditions. For example, when depression seen in a post-myocardial infarction is treated, the outcome is not merely due to antidepressant drugs, but also due to treatment and rehabilitation of the cardiac conditions. Clinical experience also shows that doses of antidepressants required are less in these comorbid conditions than they would be in a primary depressive disorder. Thus, it is important to understand that physical illnesses can coexist with severe mental illnesses and suicide. Medical disorders are known to lead to depression, which in turn is responsible for ideas of suicide. The association and coexistence of depression and suicide is pathophysiologically related. The two do not merely coexist. There seems to be a pathological pathway. Though the mechanism of suicidal ideation and depression is not well understood, a number of biological factors do mediate the psychological and behavioral responses. These factors can be cognitive, psychological, or biological. One of the important barriers for prevention of suicide continues to be poor identification of psychiatric disorders in patients with suicidal ideas. It is a major challenge. A majority of these patients remain undiagnosed and untreated. It is expected that with most facilities for education and training of health and non-health professionals could lead to better identification of such patients.
Suicidal thoughts are particularly common in the younger population. A number of individuals who are at risk for a psychiatric disorder or in a phase wherein they have not developed full-blown disease are particularly vulnerable for suicide. A study published in Journal of Psychological Medicine in 2013 supports this. In a subject population of more than 20,000, about 6.3% of subjects above the age of 16 were found to have suicidal ideas. The study was a national survey, epidemiological data for a suicide prevention program of at-risk individuals. In this study, insomnia, religion, marital status, depression, social dysfunction, and anxiety were seen to be significant predictors.
Though it is not well understood how physical disorders lead to suicidal ideation, a common emotion found is hopelessness. It is likely that some medical conditions lead to the emotional response of depression, which in turn, in conjunction with several psychosocial factors, may be responsible for suicidal ideations.
As stated earlier, suicide behavior is related to a range of severity in physical as well as mental disorders. Of particular significance are minor mental disorders, at-risk mental states, and subclinical physical conditions. All three, suicide behavior, physical illnesses, and psychiatric syndromes, have both short and long-term consequences. In a nutshell, physical and mental disorders are linked and can lead to depression and other disorders. This means that training and education for identification in the primary call is of paramount importance.
Let's now take a look at the interface of suicide, medical disorders, pharmacological challenges, and physical illnesses. An example of this interface are psychiatric syndromes that arise from medications given for physical illnesses. For example, in cancer chemotherapy and corticosteroids. Also, ongoing psychotropic medications can lead to a number of physical conditions. For example, treatment with antipsychotic medications can lead to weight gain, hypercholesterolemia, and glucose dysregulation. Sometimes, acute psychiatric symptoms like delirium or a confused state are a result of drug-to-drug interaction. A number of medications used for the treatment of physical disorders like cancer chemotherapeutic drugs, corticosteroids, oral contraceptives, and beta blockers can also lead to depression. Psychotropic medications can also lead to medical disorders. This, combined with other factors, results in the fact that the average life of a mentally ill person is about 20 years less than that of general population. As mentioned previously, ongoing psychotropic medications also lead to a number of physical conditions. Example, treatment with antipsychotic medications leads to weight gain, hypercholesterolemia, and glucose dysregulation. Sometimes, acute psychiatric syndromes like delirium or confused state are a result of drug-to-drug interaction, resulting in increased serum level of psychotropic medications. Clozapine, for example, may potentiate effects of corticosteroid or antihistaminic drugs.
Non-psychotropic medications and the drug-drug interactions can lead to other problems. A decrease or increase in blood level, worsened or newer side effects, and emergence of previously missing psychiatric syndromes. These emerging psychiatric symptoms might include delirium, cognitive dysfunction, depression, suicide, or brief psychotic episodes. Clinical practice for management of physical illnesses, psychiatric disorders, depression, or suicide is complex. For a general practitioner, it is challenging to manage these along with routine obligations. However, even a small amount of change in practice will be of great benefit to patient care. A number of steps can be taken that will be sufficient for good management of medical disorders and physical illnesses. These steps can include community care, frequent medical assessments, weight monitoring, regular EKGs, metabolic monitoring, behavioral intervention, lifestyle management, reducing risk factors, minimizing doses of medication, assessment of suicidality, managing adherence and compliance, and closer liaisons with primary care. Studies show that more than 98% physicians feel the need for training in the field of suicide prevention, and its demand is well established. This is also seen amongst non-psychiatric specialists. General practitioners feel lack of support from mental health services, and they find it difficult to refer or have the patients treated early and demand more facilities. Modern research has clearly demonstrated that training of physicians and counselors can identify people who are suffering. These attempts are largely successful in program-based community practice. Besides clinical management, a public health approach is also necessary in primary care practice. Training and education for early identification and intervention of suicide is possible by ongoing educational programs. Educational programs have very specific significance for mental health services, particularly in primary care. Research has unequivocally shown that one of the ways to reduce rate of suicide is to educate family physicians. Such programs are tailored towards local needs. We believe that training and education will lead to manpower development, and this will be the most economical and effective way of identification, intervention, and prevention of suicide. The major areas of training would be identification, crisis intervention, brief therapy, timely referral, and postvention.
The content of discussion in this module is the minimum basic information which every physician needs to know. It is by no means a comprehensive account of depression and suicide. Reading and practicing the techniques described in this course is likely to facilitate identification of suicidal patients amongst those who are attending primary care clinics. Much more discussion is required for such identification in the general population. Further modules shall deal with intervention and management of these patients. Those chapters will discuss what practically a physician should or shouldn't do whilst dealing with suicidal patients.
Nowadays, family physicians are more important professionals in the system of medical treatments as they are in contact with patients as well as families. They are also responsible for organizing a comprehensive care. To identify patients who are having suicidal ideas, we need to go to the community and approach healthcare facilities. Significant number of patients attending medical settings have suicidal ideas. While developing newer facilities for medical care, some important factors are worth considering. For example, the facility should be easily accessible. The care needs to be affordable and adequate for all consumers. In this background, family physicians have acquired a leadership role. Patients with suicidal ideas are seen across a number of settings. For example, primary care, general hospital setting, psychiatric hospitals, and psychiatric specialty clinics. A general practitioner is kept in contact by physicians of these facilities because after discharge, the patients come to live in community and receive treatment from family physicians. It is an important aspect to note that there are strong arguments to work with family physicians. Studies suggest that more than 50% patients contact their family physicians before making an attempt. Further, in many conditions, contact with family physician is the last contact before making an attempt. Elderly patients attend family physicians' clinics more frequently. Generally, it is perceived that adolescents do not visit the family physicians to address their health problems. However, about 25 to 30% adolescents attempting suicide have reportedly contacted their physician prior to an attempt. Family physicians have high skills to identify patients who are suicidal. They can provide adequate treatment and also refer the patients for further treatment well in time. Working with family physicians is also important because they can offer long-term care, monitor compliance, and attend to any crisis situation. Robust literature suggests that a number of methods employed in general practice can reduce suicide attempt, increase identification, and provide brief intervention to their patients who have suicidal ideas. A number of patients who have not developed frank symptoms of an illness also have strong suicidal ideas and in fact do attempt suicide. Suicidal behavior is often a starting point for the earliest treatment. Thus, doctors should be vigilant towards early signs of mental disorder and suicide. Depression and suicide are closely related, and about 17 to 20% patients are likely to attempt suicide during their lifetime. Treatment provided for depression leads to prevention of suicide. Treatment of depression has been recognized as a very effective method of reducing the rate of suicide. When symptoms of depression are more severe, physicians are able to detect suicide with more accuracy, and they can also refer a patient well in time for treatment by specialists. About 40 to 50% of all patients seen in clinics of general practice have depression, and these patients are treated with antidepressant drugs. Use of antidepressant drugs by family physicians also reduce incidence of suicide. a large number of physicians have expressed a need for training for treatment of suicide. Studies were conducted to find out if general practitioners can identify patients with suicidal thoughts after they receive proper education. The results confirm that indeed, by providing proper education, general practitioners can identify patients with suicidal thoughts and successfully treat them. Education increases their ability for identification, and they feel more comfortable for treatment and referral for specialist care. It is therefore obvious that a general practitioner plays a very important role in suicide prevention by identifying, treating, and referring for emergency care.
A detailed description of methods and measures to identify suicide and depression are covered here. These include asking key questions about suicide directly, use of screening tools, and carrying out a detailed interview. The description of methods given are for the purpose of reasonable knowledge so that physicians can try the one that works best for them. Here we describe a recommendation given in a World Health Organization publication for identification of suicide in general practice. We further describe clinical picture, presentation, and screening tools for depression and suicide. The World Health Organization has developed a document titled Preventing Suicide, a Resource for Primary Health Care Workers. This gives a very good account of identifying suicide in primary care. Some of the contents here are taken from its chapter, How to Identify a Suicidal Person. Symptoms of suicide behavior are withdrawn behavior, inability to relate to family and friends, psychiatric illness, alcoholism, anxiety or panic, change in personality showing irritability, pessimism, depression or apathy, change in eating or sleeping habits, earlier suicide attempt, self-hatred, feeling guilty, worthless or ashamed, a recent major loss, death, divorce, separation, etc., family history of suicide, sudden desire to tidy up personal affairs, writing a will, etc., feeling of loneliness, helplessness, hopelessness, suicide notes, physical ill health, and repeated mention of death or suicide. When the primary healthcare staff suspect that suicidal behavior is a possibility, the following factors need to be assessed. Current mental state and thoughts about suicide and death, current suicide plan, how prepared the person is and how soon the act is to be done, the person's support system, such as families and friends. The best way to find out whether individuals have suicidal thoughts is to ask them. Contrary to popular belief, talking about suicide does not plant the idea in people's heads. In fact, they are grateful and relieved to be able to talk openly about the issues and questions they are struggling with. It is not easy to ask a person about his or her suicidal ideas. It is helpful to lead into the topic gradually. Some useful questions are: do you feel sad? Do you feel that no one cares about you? Do you feel that life is not worth living? Do you feel like committing suicide? When to ask these questions? When the person has the feeling of being understood, when the person is comfortable talking about his or her feelings, when the person is talking about negative feelings of loneliness, helplessness, etc. What to ask? To find out whether the person has a definite plan to commit suicide. Have you made any plans to end your life? Do you have an idea of how you're going to do it? To find out whether the person has the means. Do you have pills, a gun, insecticide, or other means? Is the means readily available to you? To find out whether the person has a fixed time frame. Have you decided when you plan to end your life? Before discussing about using these brief scales or instruments, it is important to recap main clinical symptoms and their presentations in patients suffering from suicidal ideas. It is rare that patients report only suicidal ideas. These symptoms are always combined with either psychiatric symptoms or an adverse social situation. Commonly, patients suffering or harboring suicidal ideas are able to hide, despite the fact that they need to talk and discuss matters. In such situations, they need time to connect and talk. Most common psychiatric symptoms associated with suicidal ideas are anxiety, depression, hopelessness, or at times an abnormal behavior. Patients may seclude themselves to make an attempt of suicide or even violence. They may become mute or guarded and non-communicative. Patients may also present muteness, violence, agitation, and hallucinations. One must also note that suicidal ideas may persist even without any of the above symptoms. They may appear suddenly without any pre-warning. Some patients suffer from a psychotic disorder related to depression or schizophrenia, may start hearing voices known as command hallucinations. These voices are of variable nature, intensity, content, and may direct a patient to commit suicide. This often causes patients to attempt suicide. Relationship stress, bereavement, family problems, loss of jobs, academic stress, extreme social stress are also some of the psychological situations which may precipitate or present as suicidal ideas. Independently, any of the above mentioned factors or a combination of these can present as suicidal crisis, which is a psychiatric emergency that sometimes becomes life-threatening. A tactful handling of such patients is required.
Possible ways of identification. By promptly checking on the patient whenever suspected, by incorporating risk assessment for suicide in regular clinical checkups, and by paying strict attention to warning signs. According to the paper, Warning Signs for Suicide, Theory Research and Clinical Applications by M. David Rudd and Alan Berman, the common warning signs for suicide are someone threatening to kill or hurt themselves, someone looking for ways to kill themselves, seeking for access to pills, weapons, or other means, someone talking or writing about death, dying, or suicide. They may also feel hopelessness, rage, anger, revenge, acting reckless, or engaging in risky activities, seemingly without putting any thought, feeling trapped, like there's no way out, increasing alcohol or drug use, withdrawing from friends, family, or society, anxiety, agitation, unable to sleep or sleeping all the time, or having dramatic changes in mood. Patients with depression commonly present with three main features: depressed mood, medically unexplained symptoms, multiple pains and aches. Other common symptoms seen in depression are hopelessness, sadness of mood, loss of interest, inability to experience pleasure, weight loss, loss of appetite, suicidal ideas, helplessness, sleep disturbance, memory problems, anxiety, somatic symptoms, and loss of libido. There are simple and easy methods for identifying suicide and depression. Questionnaires and psychological tools used for identification take long and thus have limited utility. This has led to development of brief and effective questions. These questionnaires are specific, sensitive, easy to administer, and can be used in a busy practice. Though many exist, one of the most common scales for identification is the Beck Suicide Ideation Scale. Besides these, there are also several scales that identify depression, which also can detect suicidality. Research has shown that of all the items in the Beck Suicide Scale, 2 questions have been very effective. This past week, have you had any thoughts along the lines of, life is not worth living? What about thinking you'd be better off dead? A positive answer to these 2 questions together can identify a large number of patients with suicidal ideations. PRIME-MD is another suicide identification scale. On a day-to-day basis, use of the 2 PRIME-MD screening questions followed by either the rest of the clinician-administered PRIME-MD or 2 quick questions from Primary Care Evaluation of Mental Disorders, PRIME-MD, can provide us with a highly sensitive but not very specific screening test for depression. Have you been bothered by little interest or pleasure in doing things? Have you been feeling down, depressed, or hopeless in the last month? If a patient responds positively to these 2 questions, only 4 follow-up questions are needed to confirm a diagnosis of depression. These will be on the topic of sleep disturbance, appetite change, low self-esteem, and anhedonia. If a patient has a positive response to at least 2 of these 4 questions, the specificity of a positive test increases to 94%.
Scales for detection of depression include General Health Questionnaire, GHQ-12, International Classification of Disease Primary Care, ICD-10-PC, Hamilton Depression Scale Items, HDRS, and the Montgomery-Åsberg Depression Rating Scale, MADRS. GHQ-12 is a 12-item inventory. It was developed in 1960 and has been used in almost all major research. Asking all 12 questions are more useful, however, for practical purposes, a physician may only ask those questions which are most sensitive. The following 2 items are specific for diagnosis of depression and can be easily asked in family practice. Have you been feeling unhappy and depressed? Have you felt constantly under strain? An affirmative reply screens presence of depression, and then the patient can be examined in detail. Adding a 3rd question will further increase the chances of detection. Is there something with which you would like help?
The following 2 questions also have high sensitivity and specificity and can be used to good effect. During the past month, have you often been bothered by feeling down, depressed, or hopeless? During the past month, have you often been bothered by little interest or pleasure in doing things? From studies in India, it has been found that in its cultures, the questions which can also detect depression are: in the past month, have you been feeling depressed? In the past 1 month, have you felt loss of pleasure? One can ask any set of questions described here in place of all 12 items of GHQ. Another questionnaire developed by the World Health Organization is the ICD-10-PC. In this, the first three questions show possibility of presence of depression. If answers to these questions are yes, further questions are asked. The first three questions are: during the last month, have you had any of the following complaints most of the time for at least 2 weeks? If yes, please check or mark the relevant box. Have you been feeling sad, blue, or depressed? Have you lost interest or pleasure in things that you enjoyed previously? Have you been feeling your energy decreased and or are you tired all the time? If yes to any of the above, continue below. Have you been experiencing any problems falling asleep or waking up much earlier than before? Have you lost your appetite or have you been eating much more than usual? Any difficulties concentrating, for example, listening to others, working, watching TV, or listening to the radio? Has your interest in sex decreased? Have you felt negative about yourself or lost confidence? Have you thought of death, wished that you were dead, or tried to end your life? Do you often feel guilty?
It is important to remember that a number of patients of depression also present with the symptoms which are expressed during general discussion between doctor and patient, and these questions are also indicative of depression. For example, multiple aches and pains, anxiety, and sleep disturbance. These symptoms are also common in non-psychiatric patients. A psychiatric patient is a high-risk person for suicide attempt. Therefore, all these patients need to be examined for presence of suicidal ideation. Suicidal ideation is common amongst those suffering from a number of medical disorders, particularly prolonged and debilitating conditions. A number of these patients actually go on to attempt suicide. It is important to keep in mind that some of the specific groups of patients are always at high risk for suicide attempt. While a suicide attempt is possible in any patient, there are certain high-risk groups who always remain at risk for suicide attempt. These include patients with recent suicide attempt, history of past suicide attempt, alcohol and drug addiction, a family history of mental disorder, a family history of suicide, presence of psychiatric disorders, presence of depression, and current severe stress. The content of discussion in this module is the minimum basic information which every physician needs to know. It is by no means a comprehensive account of depression and suicide. Reading and practicing the techniques described here is likely to facilitate identification of suicidal patients amongst those who are attending primary care clinics. Much more discussion is required for such identification in general population. This module will follow a list of questions for self-assessment. Further modules shall deal with intervention and management of these patients. Those chapters will discuss what practically a physician should or shouldn't do whilst dealing with suicidal patients.